I just want to welcome you again to the last of the webinar series 2025, the use of PSMA imaging in prostate cancer and more. We have four keynote speakers today. Very excited to present the four speakers. Before we go ahead, I just want to remind everyone a couple of parameters for the webinar. Please familiarize yourself with the control panel. Um, if you have any questions, there is a Q&A after the presentation. Please send in your question ahead of time. And if we are short on time, unfortunately, you can send us the question and we'll do our best. And I'll do my best to send it to the right people for them to answer. It is an hour webinar, though we have four speakers and we want to hear what they have to say. So this might be a little longer than an hour. So we'll see what we can do with the Q&A period. So without no further ado, let me introduce the four speakers for tonight's presentation. Let's start with Dr. Mina Swiha. He's an assistant professor of Theranostics and molecular imaging at London Health Science Centre and Western University, where he leads the PSMA radioligand therapy program. He's a dual trained in oncology and nuclear medicine, and he brings extensive international experience that includes a clinical oncology residency and PhD in breast cancer in Egypt, a nuclear medicine residency in Canada, and a prostate theranostic fellowship in Australia under Professor Louise Emmett, contributed to the ESNA-P clinical trial and holds a certification from both the Royal College of Physicians of Canada and the American Board of Nuclear Medicine. His research focuses on prostate cancer theranostic imaging biomarker and molecular predictor of treatment response. Dr. Swiha, thanks for joining us tonight. We really appreciate it. Our next speaker is Dr. Robert Hamilton. He's a urologic oncology at Princess Margaret Cancer Center and professor of surgery at the University of Toronto in Canada. He is the Fleck Tannenbaum Chair in Prostatic Disease and the program director of the University of Toronto Society of Urologic Oncology Fellowship Program. His clinical and research interests are in prostate and testicular cancer. In prostate cancer, he is exploring the role of pharmacogenomic in personalized chemoprevention, with particular interest in statin medication and testicular cancer. His interest includes novel biomarker and studying means to minimize treatment morbidity. Dr. Hamilton trained at the University of Toronto, completed a Master of Public Health at the University of North Carolina at Chapel Hill, and a research fellowship at Duke University. He completed his fellowship at Memorial Sloan Kettering Cancer Center. Dr. Hamilton, thanks for joining us tonight. Our next speaker is Dr. Maria Young. She is a GU medical oncologist at Princess Margaret Cancer Center and an assistant professor at the University of Toronto. She completed her medical oncology residency in Toronto, fellowship at PM, and master's in science and clinical epidemiology at Harvard. T.H. Chan School of Public Health. Her research focuses on targeted therapy in GU malignancies. Dr. Young has received multiple research grants, developed several investigator-initiated trials, and was awarded the Medical Oncology Training Program Outstanding Teaching Award. She serves as co-lead of the Theranostic Working Group at UHN and PM representative of the Canadian Cancer Trial Group. Thanks for joining us today. And last but not least, Dr. Patrick Vijhybach will be our last speaker. He's a dual certified radiologist and nuclear medicine physician at the Joint Department of Medical Imaging in Toronto. He completed medical school in Germany, Switzerland, US, and New Zealand. He spent his residency and training in Germany and Switzerland. Dr. Vijhybach joined the GDMI in Toronto in April 2017 as a director of the PET-MR program. Since then, he assumed the position of division head of abdominal imaging at GMI, as well as deputy radiologist in chief, and currently serves as the managing director of neuroradiology. In addition, he has been appointed the theranostic lead at GDMI and serves as a co-director of the Silber Family Theranostics Center at UHN. Dr. Vijhybach is a full professor of radiology and nuclear medicine at the University of Toronto. His clinical research focuses on various aspects of molecular imaging and theranostics. So far, he has published over 260 peer-reviewed articles, authored books, chapter about molecular imaging in over 10 books, and served as editor of 4 books. He holds several competitive and as well as industry-supported grant for molecular imaging and research. Dr. Vai Habak, thank you for joining us tonight. So, with no further ado, we will start the presentation with Dr. Swiha, and we will see you afterwards for the Q&A portion. Thanks for being there, everyone. Let's get things started.
Thanks, Nicholas, for the kind introduction, and thanks, Canadian Association of Nuclear Medicine, for the kind invitation. I will start sharing my screen. So today I would like to explore with you the PSMA Theranostics in early prostate cancer, from molecular imaging to precision treatment. Those are my perspectives. I would like to review the role of PSMA PET in diagnosis of prostate cancer. I would like to discuss with you the PSMA radioligand therapy in high-risk localized prostate cancer and explore the emerging and novel radiopharmaceuticals in prostate cancer theranostics. I have no related disclosures. So the ProPSMA is a phase 2 randomized trial, included almost 300 patients, was conducted in Australia, led by Professor Michael Hoffman, and it included patients with newly diagnosed high-risk prostate cancer, and all the patients were randomized either to PSMA PET scan for staging, or they have the conventional imaging with CT abdomen and pelvis and bone scan. It allowed crossover between the two lines of randomization, and this study was a key study which showed superiority of PSMA PET scan in diagnosis by approximately 27%. It has also showed that the PSMA PET scan had greater treatment impact and fewer uncertain results. This is a clinical pathway of prostate cancer, as you can see right now. So we have screening, diagnosis, staging, biochemical recurrence, metastatic, hormone sensitive, and metastatic castrate resistant. So the indication of PSMA PET scan, okay, as we know right now, it's standard of care in patients with high risk prostate cancer at diagnosis, or sometimes in, I will say, unfavorable intermediate risk. And for sure, the most common indication, as it was confirmed by the recent PrEP study, okay, in Canada at least, and in Ontario, is biochemical recurrence. And for sure, there's a very growing evidence right now, and it's key for the patient selection in metastatic castrate resistant, and also for response assessment. But what about the role of PSMA PET in screening and diagnosis of prostate cancer? Coming to the primary score study, the primary score study was initially a prospective phase 2 trial, included approximately 296 patients in Australia. Those patients has no diagnosis or no biopsy proven prostate cancer. The patient have abnormal digital rectal examination, and their PSA was less than 20. So the patient underwent multiparametric MRI, and the patient also had pelvic imaging with PSMA PET scan, and the aim of the study was to see the interprostatic, okay, patterns of uptake, how this can help in detection of clinically significant prostate cancer. And when we say clinically significant, we mean ISOP grade group 2 and higher. So the investigator thought about the pattern of uptake, the intensity of uptake, and the location of uptake. And very simple, if we have no uptake throughout the prostate, or we have low-grade homogeneous uptake or relatively symmetric uptake in the prostate, this is likely reassuring. However, if you have focal uptake according to the location of the uptake and the degree of uptake or the intensity of uptake, this is likely associated with higher incidence of clinically significant prostate cancer. According to the trial, they were able to generate a 5-point scoring system called primary scoring system. And score 1, very simple. This is a very interesting image they published in JNM. And as you can see, score 1, no pattern or low grade, avidity only. Score 2, when you have relatively symmetric uptake in the transitional zone or the central zone. And score 3, when you have focal uptake within the transitional or central zone, but it is more prominent than the surrounding background, I will say approximately twice as the background visually. And score 4 is any focal uptake regardless of the degree of uptake within the peripheral zone, because we know the peripheral zone is the most common site for prostate cancer within the prostate. And score 5, any focal uptake with SUV max greater than 12. This nice graph can we see here, like score 1 and 2 in primary was actually the predicted probability of clinically significant prostate cancer was low. It was less than 30%. However, with focal uptake, there is significant increase in the predicted probability. And when the piece, like when the SUV max exceeded 12, we can see that the predicted probability was 100%. In the study, they compared both the primary PSMA score and the BI-RAD score on multiparametric MRI. And as you can see here from the table and from the graph, we can see that the PSMA or the primary PSMA PET scoring system was superior in sensitivity, specificity, positive predictive value, negative predictive value, AUC, and even in inter-rater variability by Cohen's kappa. This is the design of this trial, okay, and most of the findings. The aim of the trial was not to replace the multiparametric MRI in diagnosis with the PSMA PET, but the most important thing, how can we omit or decrease the number of unnecessary biopsies for patients, especially those who have indeterminate finding on the MRI, and also to improve the detection level of patients with clinically significant prostate cancer. For sure, prostate cancer is the most common disease, like malignancy in male. In Australia, it's 1 in 5. I think worldwide it's 1 in 8, or maybe 1 in 7. And usually we use a PSMA, we use a PSA, digital rectal examination and the biopsy, and MRI is key or the golden standard for guiding this. It was found that MRI, the BI-RAD, sensitivity is 83%, which means 13% of the patient will have false negative results. Okay, and those patients will undergo biopsy for no reason, okay, or maybe for sure we can miss those patients, or those can be missed easily, okay, from diagnosis. When we added both PSMA PET scan to the MRI, the primary score to the MRI, the sensitivity increased to 97%. So the false negative, okay, dropped to almost 3%. They found also that around 19% of the patient with BI-RAD 2 to 5, okay, can avoid biopsy based on the result of the PSMA PET scan. And the value was higher in patient with uncertain, which is like, I will say, BI-RAD 2 plus some risk factors, or BI-RAD 3, which is indeterminate. The sensitivity was very high, so the positive predictive value, okay, he reached 100%. Any focal uptake, primary 5, was uptake greater than 12 on gallium, PSMA 11 was associated with 100%. And even if, regardless of the result of the MRI, with a MRI positive, okay, we can have even a lower threshold used, which is SUV max greater than 9. Very important finding that they found significant association between the SUV max, which is the PSMA intensity measure, and the tumor aggressiveness. Additional step was taken, okay, and they have like 2 data sets to confirm these findings, prospective and retrospective, almost 500 patients, and they wanted to investigate like adding both the BI-RAD and the primary scores. They created a composite score called B score, and as you can see here, these are like the 5 points of the score based on the MRI and on the primary score. And here from the bar, you can see that the P score has the highest detection probability of all grades, okay, and it was better than both the primary score and both the BI-RAD score. Currently, there is an ongoing phase 3 randomized trial, multi-center in Australia, about the value of the primary scoring, and those, like I will say, those patients will have prostate cancer with PSA less than 20, as we mentioned, all the patient and the abnormal digital rectal examination, and all the patient will have like the 660 blend to be enrolled in this trial. They will have MRI. And those who have MRI by RAD score 2 with at least one of the risk factors, maybe higher PSA or other risk factors, or by RAD 3, which is indeterminate, they will undergo PSMA PET scan. And if the PSMA PET scan is negative, okay, or have low probability, so they will not have a biopsy and they will be under follow-up only. If it is positive, they will go for the standard of care biopsy. One key difference between the practice and biopsy here and in Australia in this study is that they do, or the standard of care, they use a transperineal, okay, biopsy of the prostate, which they usually take around 30 cores, and it will have more comprehensive, sampling of the prostate. Most centers in Canada, and I will say likely North America, they will still use like the transrectal ultrasound guided biopsy. Here, I would like to highlight an important Canadian work done by our colleagues in Alberta, also in assessment of the value of F18 PSMA 1007 in loco-regional staging in 150 patients. 134 of them had radical prostatectomy, and they found superiority of the PSMA PET compared to the MRI for correlation with the final pathological stage, dominant nodules, laterality, and interesting even, which we can't imagine, it's even have better assessment to the extracapsular extension and seminal vesicle invasion. Those are like two cases from our cases here in London. And as you can see here, for example, this patient is very interesting patient. You can see here focal uptake, two lesions. I can see number one lesion is a focal intense uptake with SU max of 19 involving the mid and apical peripheral zone on the right side. And the second lesion is focal moderate uptake. I will see SU max of 7, within the basal within the basal transitional zone in this patient. This is primary 5 and the primary 3. And this is like part of the patient pathology report. You can exactly see how the lesions on the right was higher uptake. They were ISOP grade group 4, and the one which we have seen was low grade uptake was grade group 1. Additional patient, you can see this patient, he has multiple lymph nodes, he has large intensity if PSMA avid mass involving almost the posterior aspect, I will say basal to apical prostate cancer, and you can see here exactly the extra prostatic extension. You can see the bilateral seminal vesicle invasion. How about the PSMA radioligand therapy in high-risk localized prostate cancer? So for sure, lutetium PSMA have been like proven, as you know, we have multiple, more than 70 clinical trials. They started late in the treatment, or late in the disease as third or fourth line, metastatic castrate resistant, then a little bit earlier, second line before chemotherapy with PSMA-4, and moving a little bit ahead, now in hormonal, metastatic hormone sensitive, and in oligometastatic, and what about, the jump here to the high risk localized prostate cancer? The first study which questioned this was the lutectomy study. It was conducted in Australia, and it was phase 1, phase 2 study, including 20 patients. 10 patients received one cycle of 5 GBQ, and 10 patients received 2 cycles of 5 GBQs, with 6 weeks apart, and the aim was mainly dosimetry. Those patients has high risk localized prostate cancer and biopsy proven, as we can see. And interestingly, they found no significant toxicity from using the neoadjuvant, lutetium PSMA. It was grade 1, maximum grade 2. There was like no grade 3 and 5, but for sure they used lower doses. And the surgical difficulty, which is the most concerning part, will we see like some adhesions, like the same as external beam radiotherapy? I doubt, but they couldn't find. It was 75%, the difficulty was almost the same, and slightly more, I will say here, in 25% of the patient, but there was like no difficulty. Even for surgical complication, it was, Kelvin, Dendy, 1 to 2. So overall, it showed no complication with the surgery. And here you can see that the PSMA 50 response was around 45%, 55% on imaging. They showed partial response, 5% only showed progressive disease on imaging with PSMA PET, and 40% of the patient had a stable disease. As you can see here, this is a list of ongoing clinical trials. Lots of ongoing clinical trials to assess the role of PSMA radioligand therapy in high-risk localized prostate cancer. So we have the NIBI in study in Essen. They use 2 cycles of lutetium PSMA 617 and ipilimumab. We have the lupus, and they do intra-arterial injection of single dose, whatever, 7.4 or 14.8 GBQ, for prostate cancer. And we have the Starlight, which has neoadjuvant and adjuvant with SPRT, not with radical prostatectomy. We have the Preclude and the new PSMA, even using actinium PSMA. When we talk about using radioligand therapy early in the disease, our mental, we have to think in a different way from using it in the metastatic disease. In metastatic disease, for sure, we are treating the patient on palliative intent, not on curative intent, like early in disease. And also our main target is the overall survival. Okay, secondary will be the progression-free survival and the quality of life. We need the patient to live longer, okay, with a better quality of life. But in early disease, we have to focus more on the, I will say, free from biochemical progression or free from progression. Overall survival for those patients is already very good, okay, after more the majority of them. And we have to think more about the delayed side effects and safety because we don't have enough data about the delayed. Most of the patients in metastatic disease, they do not survive longer. So what could be other novel radiopharmaceuticals that can help us with less toxicity or maybe with better targeting of those lesions? We have to explore this more. So the three radiation particles we are using currently, or there are studies around it. Number one, the beta emitters for sure, which has low linear energy transfer. It has longer a range or particle range. Okay, for example, in lutetium, the particle range between 1.7 and 2 millimeter. This is why there's cross-firing, and there's some questions about the ability of lutetium to treat micrometastatic disease. And for sure, and it causes, like all betas, cause single strand DNA damage compared to the alpha, very high energy, very high linear energy transfer, and very short range, less than 0.1 millimeter, as you can see. And a new category explored recently, which is the OJ electron. And these ones, I will say, in between. So they are very close to the alpha. So they have higher linear energy transfer compared to the beta, but lower than the alpha. Okay, and they have also very short, okay, particle range. This is a scan, like this is like a slide from the pilot study. It's a phase one, phase two trial in Peter Mac in Peter Mac Hospital, and they enrolled like 30 patients. All the 30 patients they have almost the same criteria as the therapy. Okay, metastatic castrate resistant, and they tried mainly to see the dose limiting toxicity. They have three doses. And interestingly, they found that there is no dose limiting toxicity up to 7.46 cycles. And they found also that the response rate reached the PSA 50, reached 70%, which is closer to what we got from both vision and therapy. Okay, it might open for us like doors. What about alpha? Quickly, I will touch base on this. So on alpha, it's high energy, high linear energy transfer, can cause double strand. As we mentioned, actinium has been investigated. And in early, we have the neo PSMA, okay, study investigating the role in neoadjuvant before radical prostatectomy. It's a nice slide from the early work done in patient with late disease. And we can see with alpha emitters or with actinium 225, there is significant, okay, responses. However, the toxicity was higher. I will say that you noticed in the Worms Act retrospective analysis of 500 patients that xerostomia happens in 70% of the patient compared to 40% with lutetium, and there was 13% with grade 3 or higher compared to 0% with the lutetium. What about lead? Lead is also another alpha emitter, very promising. It has low uptake within the salivary glands, so it can help with this. It can reduce the toxicity. It has shorter half-life, which might be challenging of around 12 hours, so it could be challenging in the production and distribution of this treatment. But also there is like some nice, like first of human, as you can see, with nice distribution and targeting of the lesions with lead. The last one, okay, is copper 67, and this one is a beta emitter. So we have two coppers. We have copper 67, 64 for PET imaging and 67. And this one is unique in having a bivalent bonding to the receptor like a cage. So it has more retention in the tumor. Okay, will it be promising? Like I will say here, the half-life is 2.6, and we can have also SPECT imaging with it. So to summarize, PSMA PET primary score demonstrate excellent diagnostic performance, at least comparable to multiparametric MRI, and could provide value in diagnosis of prostate cancer, especially patient with indeterminate BI-RADS. Neoadjuvant lutetium PSMA RLT shows promising potential for tumor downstaging in patients with high risk localized prostate cancer prior to radical prostatectomy, but we need larger prospective trials to assess this. Novel PSMA targeted radio isotopes may offer improved micrometastatic disease management and may have lower toxicity rates. How replacing like this will represent for us an important future direction. Thank you so much.
So much, Dr. Swiha. Let's move right ahead into our next speaker, our uro-oncologist for tonight, Dr. Hamilton. Dr. Hamilton, the floor is yours.
Great. Thanks, Nicholas, and thanks very much for the invitation, Dr. Svia. That was excellent. I learned a lot from that. And yeah, as a urologist, I spend most of my life dealing with the localized prostate cancer space and biochemical recurrence space, and so we thought it was prudent for me to talk about the role of PSMA PET in those two spaces, and they're evolving quite rapidly, which is nice to see. These are my disclosures. And so Dr. Swia talked a little bit about this, so I can skip the first part because he very nicely talked about the diagnosis and how you achieve a diagnosis in prostate cancer and how PET can help us with that. Now that you have a diagnosis of prostate cancer, we try to risk stratify patients to get a sense of what their potential development of metastasis or incidence of metastasis is at the time of their diagnosis, so you can decide about initial staging imaging. And then all of that, you put together risk stratification, and you come up with a primary treatment plan. And then the idea is obviously after you initiate the primary treatment, hopefully you've cured them. But if not, the patients will have recurrence. And the most common way patients recur with prostate cancer is merely a PSA rise. So no symptoms, no imaging findings, just a PSA rise. And we call this biochemical recurrence. And we'll talk about PSMA PET helps us in biochemical recurrence and also how PSMA PET helps us in initial staging and potential management change for the initial staging process. So I don't want to dive into details on this because there's different schema for how you risk stratify prostate cancers. So please don't, get overwhelmed by the details here. But what I do want to highlight that is that it's not really until you get to the high or very high risk category of initial prostate cancer diagnosis, and it's so really not till your PSAs are 20 or even 40, and you have Gleason 9 or 10 disease, where the risk of metastasis at the time of diagnosis actually exceeds 5 or 10 or even 20%. And it's only these latter two categories where staging imaging is recommended as mandatory. Now, the NCCN lists it as possible consider for unfavorable intermediate risk. Interestingly, the CUA guideline does not. So there's a bit of discrepancy in the unfavorable intermediate risk, but for sure, once that a priori risk sort of eclipses 10%, then the recommendation to get staging imaging, becomes more mandatory. And so you may say, well, why would a more sensitive imaging modality help us here in the high risk localized setting? And that's because we know that treating the primary prostate tumor, whether that's with surgery or radiation, that can increase or introduce morbidity and side effects such as incontinence and impotence and bowel symptoms. And so, as I just mentioned, knowing that a portion of these patients have metastasis at the time of diagnosis, if you had a sensitive and specific way to determine which patients do and which patients didn't, that may alter your decision making for them. And the idea would be that if you knew who had METs and the location of those METs, well, maybe you would avert the treatment of the prostate primary. It's sort of like, there's no sense in closing the barn door after the horses have left if you're going to introduce these side effects. You may expand the treatment fields, larger nodal dissection, more radiation. You may add systemic therapy on top of your primary prostate treatment, or you may target specific oligomets. And the goal in doing those management decision changes would be to maximize the cure rate and minimize the toxicity. And what I'm about to show you is that PSMA PET certainly helps with the precursors to those two goals, but we don't yet have level 1 evidence that we can actually maximize cure rate and minimize toxicity, at least in these two clinical settings, as I'll show. The evidence is coming, but we don't have level 1 evidence just yet. So Dr. Sweha very nicely mentioned the PRO-PSMA study, which I think is the single most important study in the world of PSMA PET imaging. And I won't go into details because he went over it so nicely, but you'll see the box on the right, PSMA PET blue, conventional imaging out of the water, no matter what metric you went by or were interested in. I have to say, as a urologist, for the longest time until this study came out, and you can laugh at me, I was convinced that PET scans had more radiation dose than conventional imaging. So it wasn't until this study that I learned that PSMA PET scan has less than half the radiation dose of a conventional combo CT bone scan. So for those of us who practice in the localized disease space, that was very eye-opening for us, and I think underscored that conclusion that PET scan, PSMA PET is a suitable replacement for what we've been doing for 40 years, which is conventional imaging for these patients. And what Dr. Sweha also showed, but I'll just drive home, is because Now, okay, we know that it finds things with more sensitivity and more specificity, but does it actually change your management decisions up front? And the pro-PSMA study showed us yes, and I'll show you a couple other studies that underscore that. And the first thing was this idea of equivocal findings. And we know that conventional imaging, as much as a fifth of patients, they have these little borderline nodal enlargements, uptake on bone scan that doesn't have a CT correlate, and you sort of don't know what to make of these things. Whereas the PET scan was much more precise in the information delivery. We didn't have as many of those equivocal findings, and as a result, the knowledge of that imaging in the case of PET scans translated more concretely into management changes than it did in the arm that had conventional imaging. So about 28%, let's call it a third of patients had some sort of management decision change in the upfront initial staging space. Fast forward to now a systematic review and meta-analysis in 2023, again confirmed, if you see at the bottom there, about 28%, a third of patients had a management decision change based on the information from the PET scan. And I threw this one up because it just was published, 3-4 weeks ago now, and showed 34% of the 137 prostate cancers that they staged with PET scans, 34% underwent a management decision change. So this is a sort of a real concrete finding that the PET scan can change management in upfront initial treatment decisions. But the next question that I'm sure you have is, well, okay, it may change treatment decisions, but does that actually lead to improved outcomes? And I have to be honest that there's really no high-level data for this yet, and I will show you a little bit more about the Patron trial when I talk about biochemical recurrence, but there's no trials directly assessing this. And quite frankly, the evidence that even shows hints of this is relatively weak. I picked two just as examples here. This is a study that looked at a prostatectomy cohort, and they divided their cohort into a quote-unquote historical cohort before the implementation of PSMA PET imaging, and then a PSMA PET cohort after they acquired their PET scanner or the PSMA tracer. And what they showed was that the PSMA cohort had a much lower incidence of biochemical recurrence. And they argued that this is because the PET scan information led to more optimized surgery and more precise node dissections, et cetera. But while that may be the case, I think we have to be very cautious interpreting that. We introduce what's called a cohort effect here, where you have an old cohort and a new cohort, and there's a whole myriad of things that change over that same time frame, whether it's other staging, surgical techniques, introduction of robotics, who knows what could be into this that would explain that the PSMA PET cohort did better. It could be the PET, but it could also be other confounding factors. So I think we can't conclude from that. And then the only other study to show this in a somewhat formal way was a systematic review and meta-analysis. And it looked at 5-year biochemical recurrence and 5-year overall survival. And it was really only a handful of studies looking at each. And as you can see, it's almost unbelievable benefits of PSMA PET versus conventional imaging, to the point where I just think it's incredibly hard to believe that point estimate change in biochemical recurrence and survival at 5 years for a clinically localized prostate cancer is attributable to the PET scan information. So I think the bottom line is, in initial staging, we know it can change management in a third, but I am not convinced as yet that those changes can lead to improvements. It probably does, but we just need to prove it with proper trials, and I'll show you how we're going to get to that in future. So let's switch gears. We'll talk about biochemical recurrence, and I mentioned that about a third of patients who undergo primary treatment, prostatectomy or radiation, end up having a rise in their PSA, no clinical manifestations, no radiologic manifestations. They have this biochemical recurrence, and you may say, well, who cares about just a number on a blood test? Well, there's a window there where we can cure them, and we know that we can salvage the situation. And if we don't, we know that biochemical recurrence is associated with the development of eventual distant, mets on conventional imaging and prostate cancer mortality. And so if we could identify where the cancer cells are living at that biochemical recurrence stage, there's a definite potential to improving outcomes for these patients. The most common definitions of biochemical recurrence, it differs whether you had a prostatectomy as your primary treatment or if you had radiation as your primary treatment. These are the two most accepted definitions. And while the radiation one is pretty standard across the world, I have to admit that the post-prostatectomy one varies a little bit depending on your guideline, whether it's 0.2 or 0.4. NCCN uses 0.1. but you get the idea. It's a very low level of PSA where you have a consistent rise and then you eclipse a certain threshold and you declare them as biochemical recurrence. And now as the clinician, it behooves us to do something about it. And this was the traditional algorithm that we had. Like 30, 40 years, we've been following this concept that once patients meet that definition of biochemical recurrence, well, now you have to make a decision. Do you institute salvage therapy? So if they had a prostatectomy, do you radiate the prostate bed and the pelvis? If they had radiation, do you go back and do a prostatectomy and remove the prostate? Or do you forget that and you just start them on androgen deprivation therapy to suppress testosterone and suppress the prostate cancer growth? And in Europe, this was actually quite popular. A lot of people said, forget biochemical recurrence, we'll just watch the patients. And eventually, when they develop symptomatic METs or conventional imaging positive METs, well, then we'll treat them. And so this was the paradigm that we were living in for decades. And now our new paradigm has the possibility, and we've been lucky in Canada, have access to PSMA PET for many years now in this specifically in this biochemical recurrence space. And it's opened up this whole world of identifying oligometastatic disease that we think we can go in and treat, and we think that we're benefiting the patients. I think we are, but as I'll show you in a second, we don't quite have the data to back that up yet. But why is PSMA PET so vitally needed in this biochemical recurrence space? Remember, the PSAs are 0.2. So for decades, we used to order conventional CAT scans and bone scans because the guidelines told us to, but the reality is that they were positive in much less than 10%. In the case of bone scan, less than 5%. And I know I don't need to tell a group of imaging scientists on the call that CT scans, they rely on a certain tumor burden to actually see something. And the resolution less than a centimeter is very limited. Same with bone scan. It doesn't image tumor, it images the osteoblastic response. And so you need to have a sort of minimal tumor burden. And the reality is that at PSAs of 0.2 and 0.3, we just don't have the resolution or sensitivity to pick those up with conventional imaging. And this is a very nice meta-analysis that looked at 67 studies or 7,000 patients and showed that the diagnostic accuracy in biochemical recurrence specifically was vastly superior for PSMA PET as compared to conventional CT scan, especially almost double the accuracy. And if you just restrict to bone metastasis, bone scan performs fairly well and comparable to PET scan, but overall doesn't perform anywhere near as well as PET scan. And if you're looking just to hang your hat on a sensitivity or specificity specifically for biochemical recurrence, it's about 84% sensitive and 97% specific. However, we have learned, and you probably know this already, that the PSMA PET positivity is directly linked to the PSA level. And this has been honed over a number of studies, and I think this is the best one to show that if your PSA is less than 0.2, only about a third of the time is your scan positive, but that goes up quite quickly. And while your PSA is still very low, you get as much as a half and even 3/4 of your PET scans end up being positive. And just to show that those international data are reflected in Canadian data, Dr. Metzer leads our PrEP registry here in Ontario. And we looked at the same thresholds of PET positivity, and we found basically exactly the same thing. Not much utility when PSA is less than 0.1, but as your PSA goes over 0.1, you sort of have almost an exponential uptick in your PET positivity and utility of ordering your PSMA PET. So again, just like initial staging, we say, well, that's great, you find stuff, but does it actually lead to changes in management? And you'll remember in the primary disease, we said about a third of the time it led to management changes. In biochemical recurrence, many of the studies have borne out that as much as 50, even 60% of the time, the management changes. And this was again by Metzer Canadian data, and the vast majority went from standard of care salvage radiation plan to now oligo or metastasis-directed therapy. So quite a difference in what is actually being done for these patients. The question again becomes, does this improve outcomes? We don't have any high-level evidence to suggest that it does. I think all of us think that it does, but we don't have any high-level evidence yet. So we have some corollary evidence, and I'll just quickly show that. This is the STOMP trial that you may have heard of in prostate cancer. Only 62 prostate cancer patients, oligomets identified on choline PET, so not PSMA PET, and they were randomized to either surveillance or oligometastatic therapy. In the group that had METs-directed therapy, they did much better. Another trial that looked at this that has received a lot of press is the Oriole trial. Again, only 54 patients, 3 mets or less identified on conventional imaging, and they were either watched or treated with radiation. And when they were treated with radiation, that group did much better. And you may say, well, what does this have to do with PSMA PET? And you're right. This is sort of corollary evidence. But what's interesting is the Oriole trial, in the group that was treated with radiation, they had a blinded PSMA PET scan done. And if the patients got so lucky that their blinded PSMA PET lesions actually were treated with radiation and all the lesions were treated, they did incredibly well. If the group had any untreated PSMA avid lesions, that group did really poorly, and sort of it gave us insight into, well, maybe if we actually could direct our salvage radiation therapy towards PSMA PET avid lesions, maybe we could have everyone be on this top curve and have very impressive outcomes after salvage radiation therapy. And it was only recently, and this just came out in the last month and a half, for the first time we have some prospective evidence, and this is a phase 2 trial looking at 128 patients with biochemical recurrence, and it's Canadian-led. This is led by Dr. Cynthia Menard at CHUM in Quebec, and they looked at either conventional sort of salvage radiation therapy given post-prostatectomy or PSMA PET intensified radiation therapy. And they looked at this endpoint of failure-free survival. And it was interesting, the PET scan led to some important additions. It broadened the pelvic radiation field. It in 30% of the time led to boost to lymph nodes, prostate bed boosts, and METS-directed therapy. And it was there's no question that the group that had PSMA PET intensified radiation therapy did better. And so for the first time, we have some prospective data that suggest that targeting the radiation towards the PET scan may be better. Now, we will have what I think will be the definitive trial in this space, which is the PATRON trial, PSMA PET guided intensification of therapy in patients at risk for advanced prostate cancer. And I'm very pleased and honored to be the urology chair for the trial. But this is going to answer 2 questions. One is the upfront high-risk staging, and 2 is the biochemical failure or biochemical recurrence. And the idea is that you lock in your standard of care plan for both of these clinical states, and then you're randomized to either getting a PET scan and intensifying your treatment according to the PET scan, or you execute your standard of care plan, and we're going to then look at failure-free survival. This trial is fully accrued now and is expected to read out in 2029. So I'll summarize with 3 points, and reminding that what we talked about was PSMA PET initial staging clearly outperforms conventional imaging. It leads to management change in about 30%, but we don't yet have high-level evidence to suggest that those changes improve outcomes, even though we think it does. PSMA PET and biochemical recurrence, similar story, outperforms conventional imaging, leads to management change in 60%, but we don't have level 1 evidence as yet that improves outcomes. Again, we think that it does, and all of us are practicing this world where we use this all the time, and we are guiding radiation and salvage therapies towards PSMA PET imaging. But if we're being honest, we don't have level 1 evidence to show that we're benefiting patients. But the PATRON trial, which will come out in a few years, I think will clarify that for all of us. So I'll stop there, and thanks again, Nicholas. I appreciate the opportunity.
Thank you, Dr. Hamilton. That was great. Let's jump right in with Dr. Jiang, our GU medical oncologist for tonight. I will remind everyone to send in the question for the Q&A. If you can please indicate which speaker your question is intended to, and you can send your question in the Q&A. And without further ado, Dr. Jiang, the floor is yours.
Thank you so much. What a wonderful discussion so far. So I'm a medical oncologist, so I'll be talking a little bit more on metastatic prostate cancer. And as you know, this is not a curative setting, but I still think that there is a lot we can do to try to improve the quality of life of patients and also their survival outcomes. So these are my disclosures. So I just wanted to sort of give a framework on when we're talking about prostate cancer to just make us on the same leveling field of which disease state we're talking about. So prostate cancer, as you know, is a very heterogeneous disease, and also there are many different disease states where the treatment options we have are different, the goal of treatment is different, and patients' outcomes are different. So for me, I'll mostly be focusing on metastatic prostate cancer. So these patients are either relapse after their local therapy or they're presenting initially with metastatic disease. Without going through all of the details for the treatment for metastatic hormone-sensitive prostate cancer, this is a disease state where we start the patient on standard of care hormonal therapy in a palliative setting, and their PSA initially can respond for a while. We initially started treating this disease back in the day with just ADT alone. And later on, back in about 2015, 2017, we started having numerous trials, and that demonstrated that by adding additional systemic therapy to ADT, we can prolong the survival of these patients by many, many years. So you can see the hazard ratio here, but when you look at the median survival improvement, it's even more impressive. And these drugs have actually more bang for our buck when we move them earlier in the hormone-sensitive prostate cancer setting. And these patients sometimes can now live 5 years, 8 years, 10 years, or we're seeing patients who are living beyond that as well. We also have some earlier phase studies, some of these studies that you've just seen before, where you have this oligometastatic disease, so they're hormone sensitive. And some of these trials are now showing that by radiating some of these limited metastatic volume disease, we're able to essentially improve their ADT-free survival. So basically, extend the time that they're not requiring hormone therapy. And we also have a more recent Extend trial that looked at actually combining this approach with radiation to limited volume of metastatic disease to continuous ADT, and that also showed improved progression-free survival. I think we do have to be mindful that if we have a patient, especially on conventional imaging, that shows metastatic disease, we do have level 1 evidence from multiple phase 3 studies that I've shown earlier that ADT plus ARPI, or one of these oral drugs, ABI, enza, apalutamide, darolutamide, plus or minus chemotherapy, improves overall survival compared to control. But these earlier phase studies do not yet have level 1 evidence, as they're smaller studies on phase 2 trials. So ideally, we're selecting these patients on a clinical trial. So when we think about what to do for hormone-sensitive prostate cancer or castrate-sensitive prostate cancer, is we're still using conventional imaging to delineate whether patients have low-volume disease or high-volume disease. And this is based on the charted criteria. We're defining 4 or more bone mets with at least 1 outside of the vertebral column or the pelvis, or if they have lung or liver metastasis. So these patients will be classified as having high volume disease on conventional imaging, where we actually think about giving further intensification by adding docetaxel chemotherapy. Whereas in patients who have low volume disease, for example, lymph node only or very few bone metastasis, we're usually just using ADT plus ARPI hormone doublet, and we also consider radiation to the primary. And in this population, we also consider, germline testing and bone protective agents, as these are also important supportive care that help to mitigate some of the risk factors that we give them with long-term hormonal therapy. So when PSMA has been adopted in earlier stage disease, it's basically a little bit of a disruptor, because we're now seeing metastases that are now in the disease state of castrate-sensitive prostate cancer that are only detected on PSMA PET, not just conventional imaging. So these are patients, as you've heard earlier, with intermittent intermediate or high-risk prostate cancer or biochemical recurrence, you do a PSMA PET, lo and behold, you do find metastasis, and then they get referred to medical oncology, and then we have to figure out what to do. So when you look at all of these trials, and these are selected trials, it's not meant to be, inclusive, but for the sort of sake of time, we sort of summarize that intermediate high-risk prostate cancer, depending on the trial, we do find 15 to 20% of patients with actually distant metastatic disease. In patients with biochemical recurrence and high-risk BCR, we do find 40 to 50% of patients with distant metastatic disease. So this is something that we have to deal with, and we don't really have a lot of evidence for, as all of these trials were conducted using conventional imaging to select patients for different treatments. If we're looking at PSMA PET in patients already diagnosed with metastatic castrate-sensitive prostate cancer using conventional imaging, we also see that 40% of patients actually have volume migration. So PSMA PET is detecting even more metastasis. So more patients actually go from low volume to high volume on PSMA PET. And we also see, interestingly, potentially some patients are downstage where, you can see, let's say, a rib lesion that becomes a false positive on a CT scan, but the PSMA PET is actually negative. So how do we think about this new sort of disease state, if you will, where you have metastatic disease only detected on PSMA PET? Well, we don't have yet level 1 evidence of trials incorporating PSMA PET in the situation, and that is coming. We do have some, very interesting data to give us a sense of potentially how we might manage them. So, for example, I'm showing a couple of studies here. The top one is comparing patients with metastatic disease detected on PSMA PET only, and then also patients with metastatic disease detected on conventional imaging. And what this is showing is that the molecular findings, the molecular makeup of the cancer is different. So if you have a PSMA detected metastasis, they harbor typically more favorable molecular makeup. So there are, TP53 mutations that we associate with more, aggressive prostate cancer, and SBOP is associated with more favorable risk. And so we see basically more favorable disease on PSMA PET detected metastasis. Below, we also see studies, and this is one of them, that's showing that the tumor volume that we're seeing on PSMA PET also has prognostic association. So patients with a few metastatic disease on PSMA PET, behaves differently than patients with lots of tumor burden on PSMA PET. So what I take away from this is that the PSMA PET high volume disease, if that is shown, is not the same thing as what we used to see with conventional imaging high volume disease. And we need to make sure that the treatment decisions we're making for CSPC is actually done using conventional imaging until more evidence is available to guide us. And this is because when PSMA PET really causes volume migration, we can have the pitfall of either undertreating the patient by omitting, for example, radiation to the primary, or overtreating the patients by adding chemotherapy unnecessarily. We also can think about using PSMA PET to define tumor volume to give us a sense, do we treat this patient more like a high-risk localized prostate cancer where we give a fixed duration of hormone therapy, let's say for 2 years, versus actually treating them more like a metastatic disease where we actually give ongoing hormonal therapy until disease progression. And we have to take into consideration the biology of the disease and the clinical context. We also recently saw some data from ESMO 2025 with adding lutetium PSMA to standard of care hormonal therapy in hormone-sensitive prostate cancer, which are PSMA avid. This trial was presented in the plenary session, and it showed a positive rPFS benefit, which was the primary endpoint. This study still had quite limited follow-up, only about 20 months or so, but the rPFS is positive and the OS was not. And I should also say that there was some crossover from this study, but regardless, we're not yet seeing that the addition of this treatment improves overall survival. Overall, the toxicity of this treatment seems to be well managed, but we do see that their numbers of cytopenia is higher with adding lutetium PSMA, and there's also numerically higher secondary malignancies, which is important because in MHSPC, these patients can live for many, many years. And whenever we're moving a treatment earlier in the disease, we have to think about long-term toxicities a little bit more. And interestingly, this trial also showed that there was no statistical difference in terms of health-related quality of life. But when you look at the FACT-P total score, lutetium PSMA treated patients seem to have worse quality of life. And it may be that those grade 1 or 2 AEs, while they're not severe, do have an impact of patients' quality of life long-term. So we have to keep that in mind as well. There are upcoming trials incorporating PSMA PET for this earlier stage metastatic disease. You heard about the Patron study, and we're also currently have a dual PET study open at our center. This is a study that I designed that we're enrolling at Princess Margaret, and basically looking at both the PSMA PET and FDG PET before starting their standard of care treatment, and then having them go through this dual PET at each line of their systemic therapy later on, and sort of figuring out how does this impact our treatment plan for patients. We do have other studies either incorporating PSMA PET to look at, do we need to have any sort of local treatment approaches like radiation, or do we actually include lutetium PSMA in patients, for example, who don't do as well with the initial few months of hormone therapy? So that's sort of an overview in the MCSPC setting. In the more advanced setting of MCRPC, so castrate-resistant prostate cancer, these patients are now progressing despite usually years of hormonal therapy. And this table shows that we have, a long list of Health Canada approved therapies for this disease state, but unfortunately, these patients have limited, outcomes and often, 2 or 3 years. And most of the patients are only able to get 1 or 2 lines of therapy. When it comes to lutetium PSMA, this is really where we are mostly involved in as medical oncologists for prostate cancer. And lutetium PSMA is mainly currently used as per the VISION indication post-ARPI, post-docetaxel in patients with PSMA-positive disease. And this is where this lutetium PSA treatment has shown overall survival. There have been numerous trials, including PSMA-4 and SPLASH, that are trying to look at the role of lutetium PSMA in the pre-docetaxel setting by comparing them to an alternative ARPI when they progress. And these trials, for one reason or another, did not show an improved OS benefit, and partly also because there's a high rate of crossover. So naturally, there is also the question is, well, if we are comparing to alternative ARPI, which we know is often a treatment that we don't often use because of limited efficacy and cross resistance, how does lutetium PSMA actually compare to docetaxel chemotherapy? And this was a trial that was led by our Canadian team and presented by Dr. Kim Chi at ESMO 2025, that randomized patients with MCRPC to receive lutetium PSMA versus docetaxel. And in the classic Dr. Kim Chi fashion, they go on to crossover to the other treatment arm. So you can see that on this trial, the primary endpoint of rPFS was not different between the treatment arms, statistically speaking, but docetaxel numerically did a little bit better. And when you look at rPFS2, so your rPFS after the second treatment, docetaxel again numerically did better. And overall survival, again, docetaxel did numerically better than lutetium PSMA. And this is despite the fact that lutetium PSMA had a higher response rate than docetaxel. And it may have to do with the fact that less patients crossed over from lutetium PSMA to docetaxel. than patients who had docetaxel first and crossed over to lutetium PSMA. We have to figure out why this is. I think if patients are not going on to docetaxel after lutetium PSMA, is it that patients are too sick to get chemotherapy after? Is it they're actually declining chemotherapy at that stage? What is the reason? And I think more data should come later about that. So we showed you, all the treatment options that are available for mCRPC. So of course, lutetium PSMA is not the only treatment out there. So how do we think about patient selection? And this is I think, a topic that is of a great interest to us and patients, but we don't actually have, level 1 data on how to actually, select treatment and sequence treatments. But we do have some information based on this concept of SUV mean on the baseline PSMA PET across these 2 studies of vision and therapy, which showed that if SUV mean is greater than 10, lutetium PSMA associated with greater benefit. And in the therapy study where lutetium PSMA went head-to-head against cabazitaxel, SUV mean greater than 10 actually showed that lutetium PSMA was much more beneficial than cabazitaxel. It doesn't mean that if you had an SUV mean less than 10, that there was no benefit. I think as patients are eligible, they were still beneficial outcomes, but this particular group, if your SUV mean is higher than 10, did derive the most benefit. But when we actually look at the PR21 study that I showed earlier compared to docetaxel, we didn't really see a signal of this doing better than docetaxel. So in this study, I think they had limited numbers here, but they divided the patients based on their median SUV, and so higher than the median and lower than the median. And if they were higher, it was prognostic that patients did better, but it was not predictive for selection of lutetium PSMA and docetaxel. We still need to tease it out a little bit why this is. Is it because in the earlier pre-docetaxel setting, this is less of a biomarker? Maybe it's because the numbers are small and they cannot divide into quartiles or whatnot, but I think we need more data to figure out how to properly select patients. But until then, it is a comprehensive discussion with patients about all the treatments that we have available. As a medical oncologist, my key considerations beyond determine whether a patient is eligible for treatment or not is number 1, to really understand the disease. Is the disease rapidly progressing? You need chemotherapy right away? Is it a more indolent disease? What is sort of the disease biology behind this? Number 2 is, what is the patient preference? And as much as we have all of these options to offer, I think a well-informed patient who can make their own choices is still probably the best way for the patient. We do want to use the most effective therapy upfront, and it is sometimes a bit of a challenge to figure out which treatment would be the most effective, because we don't have, very high quality sort of biomarkers for patient selection. But this is sort of, again, taking into understanding with the disease biology, what did the patients have previously? How did they respond to prior treatment? Sometimes can give us a clue. We also want to make sure we maximize the line of therapy. We know that the more lines of therapy patients are able to have, the better they will do long term. And sometimes you have to think about how our decisions not only impact our standard of care sequencing, but also available clinical trials. And finally, how do we make sure that patients are optimized in terms of side effect management, right? So if they have baseline anemia, if they have baseline renal impairment, is there something we could do to optimize those comorbidities so patients can stay on treatment longer and have more lines of treatment? Finally, I just want to go through this very quickly, but there are so many ongoing trials with looking at PSMA RLT using extended dosing, personalized dosing, and some looking at retreatment. There's all sorts of combinations with systemic therapies out there. And there's other also agents that are beyond lutetium that you've heard about earlier as well. So there's lots going on in this area. And thank you for your attention. I think I'm going to pass it on to Dr. Pachabite Haibak.
That is Thank you so much. I appreciate that. And our last speaker, not the least, Dr. Vi Heibach, our dual radiology and nuclear medicine physician for tonight. Dr. Vi Heibach, the floor is yours.
Thank you very much. Thanks for the handover. Thanks for the introduction. So I will try to finish this talk with a focus again on PSMA imaging, but also in the realm of more of the theranostic or treatment part. And I will also talk a little bit about post-treatment imaging here. If I can advance this one. So these are my disclosures. And this is a little bit the overview, what I'm going to talk about. One is patient selection. Maria talked obviously from the clinical side about patient selection. I will concentrate a little bit more on the imaging selection. Then response assessment, again, imaging response assessment, what we are currently doing and what's currently out there. Some factors, clinically as well as imaging, associated with response, and maybe a little bit of a future directions where this is all heading. In terms of imaging selection, this is the current pathway which you see here, how we select our patients for theranostic treatment or for PSMA treatment. It looks a little complicated. It actually isn't. It basically looks for lesions which are PSMA positive and lesions which are PSMA negative. So if you have positive lesions, then you're obviously already almost good. If you have some negative lesions, for example, then it goes by these imaging criteria here. If it's lymph nodes, it's a different size threshold, 2.5 centimeter. If it's solid organ lesions like liver or lung metastasis, then it's like 1 centimeter. And if they are PSMA negative, then this is something to discuss. And negative means that it is significantly higher than positive means that it's significantly higher than the liver uptake. But if you fulfill these criteria, then you can include your patients. Basically, you're looking for the differences in PSMA positive and PSMA negative lesions. And if you have PSMA negative lesions, you go by size criteria. And then there are some other considerations where I'm going to talk about now. So we talked about some of these low uptake lesions, and then it's a discussion at the MCC about the size and the number. Again, I gave you some of the size criteria. If there is an FDG PET, for example, then you would look for the differences in uptake in FDG versus PSMA uptake. You would look for this like flip-flop phenomenon. Is there PSMA activity or FDG activity? So if it's FDG avid and PSMA negative, that would be an exclusion criteria, for example. You would look for lesions that are a spinal cord thread. So under therapy, that the spinal cord or the nerve roots would be affected. Proximal femoral metastasis, that's obviously a very common thing in metastasized prostate cancer patients. And this is always something we have in our radiology reports where it says risk of fracture. So this is something which needs to be discussed, and I will show some examples of that. We also look for fractures, fistulas, fibrotic post-therapy changes, for example, post-radiotherapy of the pelvis, if there are any fibrotic changes or fistulous changes, for example, which would need steroid protection maybe so that it doesn't get inflamed. Solid organ metastasis we talked about, and if there's extensive osseous metastasis, for example, if there's not much bone marrow reserve left, this is something to talk about in terms of how the bone marrow reserve or how the blood work of the patient currently looks like, and if this patient maybe needs a reduction for initiating therapy, or maybe even would need transfusion, or if it needs more close follow-up, for example. So these are considerations which can be all looked at from the imaging point of view. I will show some examples. So if we're talking about femoral metastasis, then again, very often the radiology report would say, or the PET report would say there's a risk of fracture. So in this case here, for example, you have these very small PSMA avid lesions here. This is nothing, too much to worry about. This is a patient which can easily go under therapy. These lesions will be treated. They're not necessarily very lytic, and they are very small. They're PSMA avid, but again, this is not, this is technically a risk, but for for the inclusion of therapy, this is not much to worry about. Similar in this patient here, for example, it's a larger metastasis on one side. It certainly involves the cortex, as you can see here on the PET, but it's mostly sclerotic. It's not much lytic. So this is something which we would still go on and treat, and don't do much about it, except maybe for bone protection medication. So that's one consideration which can be put forward. This is a little bit different here. So you see that this patient obviously has already very widespread osseous disease, and you see in the femoral neck here, this lesion is actually lytic. So this is certainly something more to worry about. You see this component here of the bone marrow, which is lytic. The cortex is still intact, but still it's PSMA avid. Another example here where the cortex is actually eroded posteriorly here, and a little bit further down, actually there was even more erosion of this cortex. So this is certainly more of a risk than the other lesions which I showed you before. So there's maybe sometimes even the consideration to have it surgically stabilized before therapy, so that there's not a significantly increased risk of fracture. Other lesions which we are looking for example, skull-based metastasis. So those patients, if it's skull-based metastasis near the neuroforamen, that needs to undergo steroid protection so that they don't get any flare phenomenon or flare complications when they are undergoing therapy. So this is certainly something to look for. And then these lesions here, which I alluded to earlier, this is just 1 centimeter, and you can see on the MIP here, it is certainly not above the liver SUV or the liver uptake. It has some uptake, but it's not as much as you want to. So this is kind of a borderline case where at the MCC, it would be discussed if this patient can undergo therapy. As I said, it is not PSMA positive considered by the guideline, but it's just around the 1 centimeter, which the guideline says. So this is certainly something to talk about if this patient should or can undergo therapy, because it's just kind of a borderline case based on the imaging criteria. Then other complex cases which we've seen before, just to show you some examples, you sometimes even have patients with brain metastasis. These are treatable. There is a publication, a small series of patients who were treated with PSMA therapy, who had PSMA therapy, avid brain metastasis. This is technically possible. Obviously, they need a very dedicated follow-up and also protection, medical medication protection to avoid any flare phenomenon or any pressure phenomenon, for example. But technically, this is treatable. This was just one brain metastasis, but we have seen patients with more brain metastasis, and that obviously becomes very, very complicated in the follow-up. Another example here, where you sometimes have hollow viscera metastasis, like in this case, sorry, that was too quick. In this case, you have this lesion here in the gastric wall, which is PSMA avid. So this is something which also probably needs to undergo steroid protection under therapy so that you don't get any perforation. You also see there was a side finding. There's a small neuroendocrine tumor. You see the contrast enhancement here. It's not PSMA avid, so different tumor entity. But again, you can even have hollow visceral lesions, which obviously need consideration before they undergo PSMA therapy as well. Then the post-therapy part. So how do we follow these patients from the imaging perspective? So this is one patient here, for example. You see the pre-therapy PET-CT, relatively widespread disease, but otherwise technically very treatable. Underwent therapy. This is the post-therapy SPECT. After 4 cycles, the PSA came down actually very nicely from 94 to below 1. And so then there's sometimes the question if they can get a therapy break. This is more of a question internationally. We in Canada currently do not have the option to give patients a therapy break, at least not much more than 10 weeks. But in this case here, for example, there are still large lesions, large PSMA avid lesions here in the pelvis, which you can see on the right side. So even if the PSA is very low, this is obviously a good reason to go on with the therapy. This is, you sometimes have these star patients. They come with a relatively low PSA to begin with. They have a relatively low tumor burden. like this patient here, and after 4 cycles, again, the PSA was 0.3, and there's nothing to see on the post-therapy SPECT anymore. So you have some of these lucky patients, and it really is pretty much defined by the tumor burden and how they're coming clinically into the therapy. And then sometimes you get these very great response patients where you basically have no target to treat anymore on the post-therapy SPECT. It would be interesting to see if we, on PSMA PET at that time point, for example, would maybe still find some smaller lesions, so that this would be also a good reason to keep going. But again, for those patients, we should have, and currently there is a discussion going on with the authorities as well, if those patients actually, they're clinically well, they have a low PSA, they have nothing on the imaging to treat any more of those patients, shouldn't get a therapy break and can get re-challenged afterwards, for example. This is one other example just to show you this. You see on the left side on the screen, you see the pre-therapy PET CT was relatively low volume at the time. Then there was a little bit of delay with the therapy initiation, and then we started to treat the patient, and you see that there's already much more disease at the time, cycle 2. The PSA was actually rising at the time, but for clinical and other reasons, the patient was given the benefit of the doubt, but PSA was still rising. And what you can see on the post-therapy SPECT CT, which is reflective of the rising PSA, is that some of the lesions in the lower part of the body, which I pointed out here, they're getting larger in extent. So even if the number of lesions is actually the same, they're partly getting larger. And we do quantitative SPECT CT after the therapy, and so we measure the SUVs like in PET on the SPECT as well. And we could see that these lesions in the lower part of the body, they were decreasing, for example, in SUV, but in the upper portion here, they look partly somewhat different as well. There's an increase of SUV. So these lesions are progressing, even again, if the number of lesions is not increasing, but some lesions are progressing by SUV. So these lesions are now driving the progression of the therapy. So this is something you can tease out on the post-therapy SPECT as well. Predictors of response clinically and from the imaging side, if you have high positivity, as Maria alluded to, SUV 10, SUV 20 is even better. You will find some data about that as well. So if you have PSMA positivity, high positivity, then that's a good sign. Some other clinical factors, ECOG 0 to 1, obviously, lower baseline LDH and ALP have also better outcome. Disease distribution is obviously a factor. So if you don't have liver metastasis, on average, these patients will do better. Early on treatment, PSA decline is a very strong factor. So you get basically your biggest bang for the buck in the first 2-3 cycles. If the PSA doesn't come down significantly during these first couple of cycles, then the outlook is a little worse for those patients, which is different, for example, compared to other diseases which we treat with theranostic concept like neuroendocrine tumors. It's completely different there, but here it's the early decrease, which is very predictive. Then if you have an FDG scan, then the FDG and PSMA discordance is obviously predictive, and Maria has this trial which will tell us more about the overall outcome from those patients as well, and the overall tumor burden, the volume basically, and previous therapy, as it has been alluded to before as well. So these are drivers of response. There's also sometimes the question, what about like other modern techniques like ctDNA? There are some sub-studies from the trials which have been shown, for example, from the ENSAPIR, from the therapy trial. So there have been sub-studies where it's been shown that high baseline ctDNA fraction is associated with a shorter overall survival or inferior progression-free survival. Interestingly, the DNA damage repair alterations, they do not preclude patients from responding under PSMA therapy. Actually, there is some There is indication that there might be even an enhanced radiosensitivity, but at the current time point, we do not have enough data to make anything predictive out of that for actual selection. One thing to consider is that the ctDNA was found to be prognostic, but not clearly predictive for PSMA therapy benefit. So, and we also currently, at least, do not have a validated cutoff when to really stop, for example, therapy or anything like this. In terms of the imaging context, overall, the ctDNA probably can be used for monitoring, and it shows the tumor burden and tumor aggressiveness, while the imaging actually shows the radioligand targetability. So that's maybe one thing to keep in mind about that. Looking a little bit into the future, dosimetry is a topic which is frequently discussed post-therapy dosimetry, or even pre-therapy dosimetry based on the PET CT, on the pre-therapy PET CT. So a lot of academic centers moving into this direction, and a lot of academic centers also, and other centers also, moving into one time point dosimetry. Your physicist will tell you that multiple time points is better for curve fitting and so on and so forth, and there are multiple papers about that, and it is true. However, one time point dosimetry works reasonably well, especially for PSMA therapy, and this will be something which we have to integrate more and more, especially in those circumstances when patients are getting earlier treatments or PSMA therapy earlier during their cancer journey, so that we know what kind of or what amount of energy they already had delivered to their bone marrow and to their target or non-target organs, so that we know, for example, if we could still give the same kind of therapy like a lutetium PSMA, or maybe even another isotope with actinium or lead or other isotopes which are out there, so that we know how much energy has been already delivered and if it would be safe to re-challenge them, for example, or give them another complete course of this type of therapy. So this is why dosimetry in the future will play a significantly increased role, so that we can safely monitor how much energy and how much dose these patients already had and how much can we still give. And this is just to show you how many, and Maria has showed a couple of other slides concerning how many trials are currently out there. We all know about the VISION trial. It's currently in the third line here, but the therapy trial was there. The Prostate is currently still under is currently ongoing. For example, we are partaking in that trial as well. Several other trials have been, like the PSMA Edition has been reported, as it was discussed here. Bullseye, ENZA-P has been partly reported, and even earlier, the LUNA trial has just reported initial results at the ESMO 2025 as well, which was mostly positive. And you even see trials in a first-line setting and in a localized primary staging or primary therapy setting as well. So just to give you an outlook where some of these therapy might end up, it's not necessarily a given that all these trials will be positive and that all these trials are going to be implemented in clinical routine. And even if all the trials would be positive, then still somebody has to pay for it. So it's not necessarily a given that we will see lutetium PSMA therapy or other theranostic concepts in all lines of therapy. But just to give you an outlook that at least in all these scenarios, it's been currently investigated, and for sure some of those indications we will see in the long term being available for patients. One other thing, as I said, we currently discussing with the authorities here in Ontario, for example, at least, if we could give patients a therapy break if they have a low PSA, nothing or almost nothing to see on the SPECT anymore, and on the post-therapy SPECT. And this is important because if you don't see anything on your image anymore, that means you have lost your target to treat, right? Probably there's microscopic disease still around, but you don't see it anymore. So the therapy effect will be relatively little. So this is a study which has looked into the comparison if you give all the 6 cycles one after the other, as the label says, or if you can give therapy breaks and then challenge them several times over the course of disease. And you can still see here very easily, actually, that those patients at least survive longer. The study also says that on average, they're doing actually very well. And this is something, because this is actually the standard of care in a lot of other systemic therapies as well, that you can take therapy breaks, for example. And this is probably something we should strive for our patients as well. Conclusion, you've seen there are many, many trials currently being conducted in multiple prostate cancer settings. Not all of them will be positive. And Maria alluded to the PR21, for example. It's not overly positive. And from an imaging perspective, the pre-therapy imaging plays a significant part, plays a vital part in therapy decision-making and qualifying those patients for therapy. And there are multiple considerations which you can draw from the pre-therapy imaging. Post-therapy imaging as well, there is partly, and there are currently studies being conducted, there's partly discordance between the clinical status of the patient, the PSA value of the patient, and what you actually see on the imaging. So that gives you additional complementary information how to move on with this patient. And again, we've seen several of those trials, so I'm pretty sure quite some theranostic concepts will be part of several levels and several scenarios of prostate cancer therapy pathways. And with this, I would like to thank you for your attention.
Thank you very much, Dr. Heiberg. This was a very informative and engaging conversation. So I wanted to thank all the speakers. I'm aware of the time right now, so we do have a Q&A period. I'm going to invite all speakers just to stay with us a little bit longer because we do have a few questions to go over. We'll try to keep them short, and then we'll finish the webinar as soon as we can. So let's jump right in. A couple of questions for Dr. Swiha. As per PROMISE paper, SUV max over 12 using gallium-68 PSMA basically indicates prostate cancer. Does the same SUV max threshold hold true for F18 PSMA radiotracer or only applies for gallium-68?
Thank you so much for the question. So first of all, yeah, PROMISE included the primary score within it. It's not validated on F18, whatever DCFBIL or 1007. We are here at LHC. I started a trial on retrospective analysis to validate it on 1007. Hopefully you have the results soon, but I still use it on any tracer, but it's not validated.
Second question, do you feel that the current PET PSMA imaging indication in Ontario are overly stringent? Do you foresee any role for PET PSMA as a one-time population level screening tool for prostate cancer?
So I think we are waiting to have like level 1 evidence. We need to have like a randomized phase 3 trial, and this is what we are going to see from the primary 2 study right now conducted at Peter Mac. So if this trial comes positive and it showed that at least PSMA PET-CT can be helpful in patient with indeterminate finding on MRI, I would expect it will be at certain time, maybe level 1 evidence, but it's not right now for sure. We have still phase 2 trials, so we can't say it's level 1 evidence at that time. Thank you.
Thank you very much. We do have a few questions for Dr. Hamilton. Dr. Hamilton, are you following up a mild, how are you following up a mild PSMA skeletal focus with no CT correlated? Do you follow with a bone scan, PSA level, or repeat PSMA scan?
Yeah, it's a good question. I think it depends on the clinical context and it depends on what else you know about that patient. So what their absolute PSA is, what their PSA velocity is. What if we're talking about initial staging, this is, depends on their Gleason score, depends on what their family history is, what other findings you have on imaging. So there's no one steadfast answer for that. I would say, generally speaking, we would follow with repeat conventional imaging. I don't think we have not been routinely repeating PSMA PETs for initial staging of sort of equivocal findings.
Thank you. New question from a technologist perspective. Is there any evidence that hydration, fasting status, or recent androgen deprivation therapy significantly impacts PSMA uptake or image quality?
Yeah, so this one I probably should defer to either Patrick or Mina. Certainly I can speak about the the androgen deprivation piece is interesting. We don't have great data to know the exact time frame of the influence of ADT and PSMA expression, but there's some data that suggests initially it causes an increase in PSMA expression within the tumor, and then after prolonged use, it decreases PSMA expression. So there's even been a couple studies looking at almost enhanced sensitivity within that early period of ADT utilization, but I don't know that we know the exact time frame of that. As for hydration and what was the other fasting, I think. I don't know,
Fasting.
Patrick,
Fasting.
if you know of any studies. I have not come across anything that's looked at that.
So there has been one or the other study which has looked at that, and you may find minor variations, but nothing is pointing towards that current practice should be changed. So fasting, like for FDG, for example, it's not a factor. There has been some high protein diet discussion, for example, I've seen, but again, nothing has really probed anybody to change practice, and hydration doesn't either.
I would say just one comment here. So for hydration fasting, I agree with Dr. Hypak. Okay, there is no evidence, but for ADT, for sure, we have like some ongoing evidence. ADT and ARBIs in particular. So ADT, it's like some studies showed as early as a few days after starting ADT in patient with metastatic castrate sensitive, you will have some reduction in response. And I always add it as a caveat if the patient started ADT. So if you are referring patient for imaging, please don't start ADT for staging. RBI, ARBI is a little bit different in patients starting on ARBI. In the trial shows that those patients can have upregulation of the receptor. We don't know exactly. We have a publication ongoing right now in Nature, and we showed that those patients likely will have very poor prognosis at even 15 days after starting them, and adding maybe lutetium in those patients might improve their prognosis. But we still, everything is early. Okay, we don't have like a strong study seeing this. Thank you.
Thank you for that. Other question for you, Dr. Hamilton. What is the optimal uptake time for PSMA PET in routine clinical practice, and how flexible is the window without compromising lesion detectability? Our site aims for 60 minutes.
Yeah, I don't even know if I'm the right person to answer that. So 60 minutes, as far as I know, is the standard. There's been some data on looking at longer times, even up to 3 hours to try and find smaller lesions. But I don't know, Patrick or Mina want to take that one. I'm not sure I'm the right person to answer that.
So there have been studies that if you wait longer, you would see one or the other lesion more. But at the same time, with the gallium, for example, you have to compromise with the short half-life as well. It's different than compared with the F-18 tracers. So, and again, 60 minutes is the standard. If you go up to 90 minutes because some patients are late or whatever, this is something which happens routinely any day, which is fine as well. Sometimes you will see on your score chart that that they have been scanned at like 50 minutes or something like that because the techs wanted to get a move on. And that's acceptable too. And everything in that time range is clinical routine. And I'm not aware of any center who's doing significantly longer, like 120 minutes or anything like that, other than for academic purposes.
I fully agree with Dr. Aibak about this. It's by the manuscript, okay, it's 55 to 100 minutes for gallium is a time for it. Delayed imaging might have some benefit, and I will not say delayed more than the same as what Dr. Aibak mentioned is 90-minute maximum, okay, because of the half-life. But if you have suspicious lesion, maybe in the pelvis, you are not sure about, you can repeat like delayed imaging, and if it has more SUV max or a little bit high uptake, this is somewhat more concerning. But to be honest, with the high resolution cameras we have right now, I doubt the value of having some delayed image, but it could be helpful in some tricky cases. Thank you.
Thank you. Two more for Dr. Hamilton. Assuming that the Patron trial confirms that PSMA improves outcome compared to CT and bone scintigraphy, do you anticipate that CT and bone scan will become obsolete for prostate cancer? Do you think they'll take some time for clinicians to fully adopt the evidence-based paradigm?
Yeah, good question. I don't think, for two reasons, I don't think that it'll completely eliminate or render obsolete conventional imaging. The first is an issue of access, and certainly in Canada, that's a huge deal. And you think about the proportion of patients who in Canada currently with prostate cancer who might have access to PSMA PET scans. It's just a small proportion that could have ready access to PSMA PET scans as opposed to conventional imaging. And I think the guidelines have been very careful actually not to say first line or standard recommendation is PSMA PET because it would introduce a disparity that could not be overcome, at least currently in Canada. And the other is, and I'm curious what the rest of the panel thinks, but I still think there is something to be said. Like a lot of prostate cancer is very visible on conventional imaging, especially when you're talking about advanced disease. And the ready availability, relative ease of access, and ubiquitous access for conventional imaging, I think will, at least for the foreseeable, say 5 years, 10 years, retain conventional imaging as a, very important factor for prostate cancer management.
Perfect. Thank you. Most PSMA PET scans have a CT image fuse for interpretation. Does this affect the benefit described in PET over CT?
Yeah, I saw that question. I didn't quite know what it was getting at, but I think the studies that have looked at PSMA fully account for the fact that there's a backbone of most often CT, occasionally MRI, but most often CT. And so whatever statistical advantages we're seeing for PSMA PET CT over conventional imaging accounts for the fact that both have CT as a backbone, and the advantages that we're seeing are the combination of PSMA PET and tracer on top of the CT as the anatomic backbone.
Again, from a technologist perspective, the question is for Dr. Vihaiback. What is the ideal timing for post-therapy imaging, and how should technologists optimize image quality given the lutetium-177 imaging characteristic? Our site will image patient usually a few hours after Pluvicto treatment number 135. We perform our vortex to mid-femur pass followed by a SPECT CT.
So there's no ideal time point really. It's ideal if you can do it on the same day just for patient comfort, right? So that's one thing. Some of the images which I showed, they were taken 4 hours after infusion. So that's decent image quality, although our cameras we're currently buying new ones, but the current ones are rather old. So 4 hours on the same day, patients appreciate that. If you are looking for dosimetry to do together with the SPECT, then you have to go to 48 or 72 hours, which is a little bit more cumbersome for patients to come back. But again, dosimetry will play a significant role so that we can monitor those patients appropriately, especially if we are moving to earlier time points in therapy. That's one thing. In terms of SPECT, I would agree 135 is probably very reasonable just for logistics. You don't probably need a post-therapy SPECT after every cycle, for example. I think that's a little bit of an overkill. You can flexibilize, or we flexibilize a little bit. So if there are questions, for example, because there are divergent findings, then we may do another post-therapy SPECT at cycle 4 or something like that. But 135 sounds very reasonable. And vertex to mid-femur is also reasonable. Most of the patients will have most of their tumor burden within that field of view. Another thing is we always do SPECT CT. You can reconstruct your whole body from the SPECT CT as well. You don't have to do 2 actual reconstructions and acquisitions. So
I will just have a comment here about the value of a SPECT, if you don't mind, Dr. Ibak, because there are different practices between centers about it, honestly, and there is a good evidence going. I fully agree there is no definite preferred time. Maybe the preferred time, most of the studies use 24 hours. 4 hours, we developed this study and we showed it's almost the same. But the most important point from this study, okay, we found differences between 4 hour and 24 hour. So we should have the same time slot. If you will image your patient at 4 hours, so all cycles should be done at 4 hours. If you will image the patient at 24 hours or 48 hours, like some other trials, it should be the same time because there are differences in the total tumor volume, differences in the number of lesions. The idea of 1, 3, and 5, it's for, I will say, logistics, it's doing well. There is some evidence about both cycle 2 and how can we use a SPECT early at cycle 2, which can for sure modify the patient, individualize. We can stop the patient treatment or put like treatment breaks in between. So the standard protocol, I will say in Australia at least, okay, they go every cycle. I will be very supportive to go every cycle if we can. The problem is the logistics and the time of the camera. And for sure, because you will find a fresh, this is the value of SPECT compared to PET. Okay, so you can have bit in between like what we do after cycle 3, but SPECT might be very helpful every cycle if you can do that. Another last thing about it, ideally you should combine with a contrast enhanced CT at least one time. So we used to do it like almost every treatment or maybe every other treatment, because you will miss the PSMA negative disease during your follow-up. So maybe mid cycles you add like contrast enhanced CT in addition to the SPECT imaging. Thank you.
Thank you. Being aware of the time right now, I think we'll answer one last question and then we'll conclude the webinar. Low PSA like 0.65 or 0.5 during the second, third, and fourth cycle treatment, but high SUV on PSMA scan, like around 20 or 30 on multiple bones showing decreasing trend of SUV. How to proceed as PSA is very low? I think the question for Dr. Hyback, but go ahead, Dr. Young.
Yeah, I can maybe take that as well. I think first of all, our patient population who are receiving Pluvicto treatment are have mostly very advanced disease. And it's actually not that common to see that after the second cycle that their PSA goes that low. So I guess it depends on where you're starting from. So we, at least to my knowledge, have not had a patient, let's say on SPECT imaging, have like a complete response after before they reach the fourth or sixth dose. So most of the time, our decision is going to be driven by patient's tolerability. So if the patient's PSA is declining, they're doing well, they're showing response, I don't see a reason for stopping. If they still have residual disease, that's even a stronger indication to continue. But I would also say that it is also important to monitor their response with conventional imaging in addition to either SPECT or PSMA PET, because you want to catch any disease that is potentially PSMA negative. And instead of just having the patient continue treatment for a long time, you want to make sure that if any PSMA negative disease is developing, that you act on that early.
Since I have you, one last question that we just got in. Does low secretory disease, low PSA level, high volume PSMA avid disease behave differently? Any prognostic significance?
Yeah, it's a great question. I think this is the part where we have to make sure we understand the disease biology, right? So, I mean, in general, if we look at the eligibility criteria for Pluvicto, if you have the target and if you don't have any PSMA negative disease, either compared to conventional imaging, or FDG PET, and their organ function is okay, and they're potentially eligible for treatment. I think depending on the situation, if you do have a patient with low PSA, this is where you really need to at least take a look at the conventional imaging, right? And in some situations, we may even think about doing an FDG PET. And if there is areas of disease that may not be adding up to the PSMA PET, you may want to think about a biopsy to rule out neuroendocrine prostate cancer. Sometimes you get a biopsy and they have neuroendocrine markers, but it's still prostate adenocarcinoma. I think those patients are potentially eligible, but sometimes we have to think about whether their prognosis is a little bit worse as well. But I think this is one area where we really have to get more information to clarify the disease biology.
Thank you very much. I think we will close the Q&A section period right now. If you do have any questions, you can send them directly to me and I will forward them to appropriate person or speaker. I just want to thank you on behalf of the Canadian Association. Thanks for all the speakers for their time. I know we went a little bit past the time right now, so I really appreciate the expertise and thoughtful contribution. I think it was very informative and engaging. I just want to thank you.